I start with a disclaimer that we are sort of shifting gears into mental health services research, and also by starting to thank the organizers of the HBHL on behalf of my co-investigators and PI, Dr. Joseph Cox. To present our work very much in progress, in which we examine the mediating role of perceived discrimination in the use of mental health services among gay, bisexual, and other men who have sex with men in Montreal. Now, as a result of the social stress of being a sexual minority, it has been frequently and consistently documented that gay, bisexual, and other men who have sex with men, or GBM, have a higher burden of mental health conditions as compared to the heterosexual counterparts. Now, as a corollary, it has also been seen that GBM utilize mental health services more than heterosexual men. Now, a lot of literature has gone into trying to identify an actionable item to explain this disparity, and perceived discrimination has emerged to be one of these actionable items by which we can explain this disparity that's observed. Despite that, little is known about how perceived discrimination mediates engagement in mental health services amongst racialized and GBM living with HIV, which unfortunately remains a very much part of the lived experiences of a lot of GBM in Canada. So for this, we use data from the ENGAGE study, which is a cohort that follows GBM across 3 Canadian cities. The study recruited cisgender and transgender men who were at least 16 years of age and who reported having sex with another man in the past 6 months. Recruitment was done using respondent-driven sampling, which is a controlled snowball sampling technique that accounts for the network sizes of each participant. And as part of study procedures, participants completed computer-assisted surveys and biomedical testing. Now, we leveraged on the theoretical framework of intersectionality, which is a framework that tries to understand how differential power structures shape the experiences that people have when they exist at the intersection of multiple social positions. Now, this framework was most made famous by Kimberly Crenshaw and applied in the legal framework, and most famously argued in a case against General Motors, in which the company argued that discrimination based on sex had not been, there was no discrimination based on sex because women were hired, and there was no discrimination based on race because Black men had been hired, completely discrediting the experiences of Black women. Now, using this framework, our objectives were to quantify the engagement with mental health services among GBM, located at social intersections that are shaped by ethnicity and HIV status, as well as to quantify the mediating role of perceived discrimination that operates at these different intersections that are shaped by ethnicity and HIV status on mental health services engagements. So our current analysis only uses baseline data from the ENGAGE study from participants in Montreal, which is about sample size of about 1,122. We categorized ethnicity based on the Employment Equity Act of Canada as white or visible minority, and because there were very limited Aboriginal people in our sample size, we included them in the group of visible minority. We quantified perceived discrimination using the everyday discrimination scale, the mean scores of which range between 5 and 25, 5 being the lowest and 25 being the highest. And we categorized mental health engagement as any or no consultations with a licensed mental health service provider that included a physician, a psychologist, a psychiatrist, a social worker, or a community-based worker in the prior 6 months. Now, to sort of formally leverage on the concept of intersectionality, we identified 4 intersectional groups. Group 1 included white GBM, who are HIV negative. Group 2 included white GBM, who are living with HIV. Group 3 included the group of visible minority GBM, who are HIV negative. And Group 4 included visible minority GBM, who are living with HIV. Now, for this analysis, we used the causal mediation analysis framework. And why we did this is because we wanted to sort of look at the direct and indirect effects. Now, because the social position itself is very difficult to intervene upon to affect the outcome, this framework helps us to identify a mediator through which we can actually intervene and therefore affect the disparity that is seen at the outcome. Additionally, in this method, we also included an intersection between the intersectional group itself and perceived discrimination. Now, what this effectively does is that it allows for heterogeneity of effects, not only for the outcome, but also for heterogeneity of underlying processes to affect the outcome. We use a logistic natural effects model, which have been recently described and directly model the direct and indirect effects using imputation or weighting techniques, and we adjusted for H as a potential confounder. Now, these are sort of our descriptive results, and our RDS report, RDS adjusted. That is that these observations have been adjusted for the network size of each participant. And in this, we see that engagement with mental health services in the prior 6 months was seen to be the lowest among visible minority GBM who are HIV negative, and highest amongst visible minority GBM who are living with HIV. Now, surprisingly, we do not observe the highest mean perceived discrimination scores among visible minority GBM who are living with HIV, but rather among visible minority GBM who are HIV negative. From our causal mediation analysis, we found that when compared to the reference group, which is the group of white GBM who are HIV negative, there was an apparent difference in the utilization of services by white GBM who are living with HIV. Now, this is indicated in the total effects that you see for group 1 and for the comparison group, which is group 2. But this utilization of services is not explained by perceived discrimination, which we see in which our indirect effects are not significant. But it does appear that group membership itself has an effect on the way that white men who are living with HIV utilize mental health services. Now, in contrast to this, when we use the comparison group using group 3, which is the group of visible minority men who are HIV negative, we see that as compared to white men who are HIV negative, there is no apparent difference in the utilization of mental health services as shown by the non-significant total effects, but that when utilization does occur, it appears that perceived discrimination mediates this effect, which is shown by the significant indirect effect in our model. Now, for the last group, which is the group of visible minority men who are living with HIV, we observed no significant direct or indirect effects. So in summary, summarizing our results, we observed lower than expected mean scores for perceived discrimination in visible minority GBM living with HIV in Montreal. Now, we have been trying to sort of think about this more clearly as a group, and we think that we need to understand our results a little bit more qualitatively, because at present, we don't know whether the lower expected mean scores for perceived discrimination that we observe in this group is a function of the fact that these men are in more frequent contact with the healthcare provider, or that it indicates a component of resiliency in this group. Also, compared to white men who are HIV negative, in the intersectional group of white men who are living with HIV, we observe that the group membership has an effect on engagement with mental health services that is not mediated through perceived discrimination, whereas in the intersectional group that is defined as visible minority GBM who are HIV negative, The group membership itself has no apparent effect on engagement with mental health services, though when engagement does happen, it appears to be mediated by perceived discrimination. And as I mentioned earlier, for the last group, which is the visible minority group of GBM men, who are living with HIV, intersectional group membership has no direct or indirect effects on mental health services utilization. Now, although these findings may seem counterintuitive in that one could argue that if we wanted to increase engagement with mental health services for the visible minority group of HIV-negative GBM, we need to increase perceived discrimination, which would not be very helpful. But these, our results, have to be understood in the social context of how engagement with services among ethnic minorities occur. Now, studies from Canada and elsewhere have documented that even after accounting for factors like access to service and socioeconomic status, ethnic minority groups utilize mental health services utilize services less frequently than their white counterparts. And they do so only after they have reached a certain threshold beyond which they feel that they cannot cope with mental health, with personal mental health by using self-reliance techniques. Now, if we sort of contextualize our results in the setting of the social context, we could sort of argue that visible minority HIV-negative men seek mental health services only after they have reached a threshold of perceived discrimination beyond which they cannot self-manage their mental health. And so it is very important that for the provision of clinical services, that when they reach a provider, the perceived discrimination is not perpetuated at the end of the healthcare provider. And as we sort of know from the recent experience from the Vancouver hospital, we know that racism does exist in healthcare setups and amongst healthcare providers. And if perceived discrimination in this group is perpetuated, it could sort of disastrously lead to worse mental health amongst this group. Our results should be sort of interpreted in the context of the limitations in which they occur. First of which is that there is a small sample size for the fourth intersectional group of visible minority GBM who are living with HIV, and that limits the inferences that we can make to this group. We also treated ethnicity as a binary variable, therefore obfuscating the different experiences that different ethnic minority groups may have. The cross-sectional nature of our baseline data makes the assessment of temporality for other potential confounders as common causes a little challenging, and so it makes it a little difficult to include them in our model. The use of the everyday discrimination scale in its current form will not adequately capture the intensity of perceived discrimination, and also in this analysis, we were limited to only using data from Montreal participants. So in conclusion, a quantitative intersectionality approach can be useful to highlight the mediating effect of perceived discrimination on engagement with mental health services, especially if there are no apparent differences in the utilization of these services amongst GBM located at different social positions. However, our results must be interpreted keeping in mind the social context in which engagement with mental health services takes place. And in sort of our next steps, our plans are to sort of use the 3-city data to formalize this analysis a little bit better, to include additional sensitivity analyses to check for the robustness of our effect estimates, and to include a longitudinal analysis so that the temporality of confounders can be better constructed. Thank you.